done many studies comparing phaco and small incision surgery. And while it is true that small incision surgery causes slightly more astigmatism because the incision is large, we can actually use this to our own benefit, because then we can, modify our incisions and modify our astigmatism more. So in many ways, it is easier to deal with astigmatism when we are doing SICS than when we are doing phaco. Professor Parikshit had asked me to speak on how we can use advanced SICS techniques to neutralize the astigmatism that is there. So Professor Lame and Professor Parikshit will be showing you fantastic videos. Before we go on to that, I will just quickly go through a few theory aspects of astigmatism. We know astigmatism is a limiting factor in patient satisfaction. We surgeons are happy with best corrected visual acuity. Patient is 6'6", N6 with specs. But patients consider the success of surgery with unaided visual acuity. Now, of course, correct IOL power takes care of the sphere, but we surgeons have to take care of the post-operative cylinder. Generally, when I was doing training, when I was doing residency in 1990s, the most common diffraction we would give was +10 sphere, +1.5 cylinder at 180 degrees with an addition of +3. We used to do ICC. That big sphere has gone away with IOLs. The small incision with SICS and phaco has taken care of the cylinder. And now, of course, the multifocals are also doing away with the reading addition. So we are actually giving our patients the best kind of vision, both for distance and near, without specs. When we look at SICS and phaco, the difference is actually very small. There is this very famous study done in Nepal, which was published in the American Journal of Ophthalmology, and there is an editorial on it. The difference is just 0.2 diopters. When we did a study in Pune, again published in the American Academy of Ophthalmology's journal Ophthalmology, there also the difference is small. So even when foldable lenses have been used in the phaco arm with diamond knives and stainless steel blades have been used in the Pune study, there is not much of difference. Post-op, of course, when we look at 6 weeks, the astigmatism in SICS is slightly more than the astigmatism in phaco. But then, as I said, we can use this slightly more astigmatism to our own benefit because it has its own uses. Let's come down to it. The phaco is, of course, the king of cataract surgeries. The SICS is like the tiger, and it is something that is equally royal and valuable. And when we want to minimize the astigmatism, how do we do that? One is, of course, we have smaller incisions. We decrease the length of the incision, the size is reduced. Or we can have a frown or a chevron, and Lahanes's excellent videos will show that to you. And of course, the internal incision matters, how it is. And we can even change the site to superior or temporal. We can go away from the limbus. But most importantly in SICS, we can choose the steeper meridian to operate. So whatever is the keratometric reading that is more, if we do our incision on that, then we can get almost astigmatically neutral post-op results. So we have this incision of an astigmatically neutral funnel. So if we go slightly behind, so even if the incision is longer, as for hard cataracts, black or brown cataracts, we can still have much less astigmatism. And of course, here the chevron incision or the frown incision is good. And when we do cams, once in a while, like I would be getting an iris prolapse. That's when Madam has said, you go behind the limbus. The more behind you go, the chances that the wound is more stable becomes much more, and the wound becomes astigmatically neutral. The only problem is, if there are too long tunnels, they decrease the maneuverability, so we have to be a bit careful with them. And finally, before I conclude, I always say there is a trade-off between lesser astigmatism, that is smaller incision size, and corneal clarity, that is endothelial cell loss. If it's a very hard cataract and we try to make the incision smaller and smaller, and we try to play a lot in the anterior chamber, we are likely to get something like this. So while we have to be, of course, careful about astigmatism, it should not be at the expense of getting striate keratitis. Because in striate keratitis will result if not care enough is taken to place viscoelastic between the nucleus and the cornea. The side port is an excellent route to ensure this. The delivery is facilitated through a trapezoid tunnel. And if the nucleus is hard, it is always better to have a larger tunnel and then suture it. And of course, in site of incision, there have been studies from Mumbai, Dr. Gokhale, Dr. Hajipurkar, Dr. Sahni. They have said that temporal and superior temporal incisions induce less astigmatism. And temporal incisions are farthest from the visual axis and gravity. And this eyelid blink creates a drag on superior incisions. So it's not just for phaco, even for SICS, we can do a temporal incision. And we have a large study we have done in Nasik, which we published in the European Journal, which shows that even temporal SICS is not just effective, it is very, very safe. And the Arvind Eye Care System, which does the maximum number of SICS, about 3 lakh surgeries, they also all do temporal SICS. So temporal SICS even can be done with an 11 number blade. And when we are looking at astigmatism, it is not just the incision size. Suppose we have to have a larger incision, then we can either use a cross suture as we see over here or a single box suture. The cross sutures are easier to place because we surgeons, that is how we are used to doing suturing. But then the entire breadth of the incision must be opposed. All of this entire incision must be opposed, not just the outer lip. But the box suture is cosmetically more appealing because it's almost an invisible suture. But again here, the entire length of the incision must be opposed. Because if we suture only the outer lip, then we can have bleeding or oozing through the inner lip, and that can lead to a problem. And of course, finally, we must ensure tunnel integrity by irrigating through the side port. And whenever there is a doubt, please suture. Another thing that can be done for minimizing astigmatism in SICS is to have nimble, relaxing incisions. Secondary can be done as an odd case that lines up with a large cylinder, but primary LRIs can be used as an adjunct procedure whenever there is a pre-existing large astigmatism, definitely when it is more than 2 or 3 diopters. And presently we have done a large meta-analysis comparing phaco with small incision, and here we have found that if we have a small residual astigmatism, it actually leads to better unaided near vision. We are so, what shall we say, focused onto distant vision. Having 6/6 unaided, we forget that patients need vision for reading and writing without spectacles. Nowadays, everyone has to answer his or her mobile phones, even people who don't read and write, or to sew or knit. And for that, if a final astigmatism is about 0.5 or 0.75 diopters, then the patients are very, very happy. And in which case, when we had seen a comparison between phaco and SICS, patients were more happy with SICS as far as near vision was concerned. So in many ways, SICS is like our Indian ophthalmologist nano. It is something which is not very expensive, but it still does that trick and gives our patient very good vision. Thank you.